The scientific endeavor is one in which we try to remain in conversation with reality, pare away our biases, etc. And in this case, the critical reality to keep our eyes on, the critical thing to remain in a relationship with, is the reality of real people's lives as we treat them, after we treat them. And sometimes that gets lost in the numbers in a paper or some public announcement or some commercial deal or whatever. I think there's so much promise in psychedelic therapies, and if we're going to figure this out, we're going to need to stay very close to real patients and their real stories and their real futures.
Dr. Paul Liknaitzky, welcome to the podcast.
Thanks, Paul. Nice to be here.
Yeah, I tell you what, setting up the audio on this is more tricky than setting up a psychedelic lab.
Not quite, but yes, that was hard.
So mate, we met, a couple of months ago now, when we both presented to the Young Presidents Organization. And I was very excited to be presenting alongside you. And the stuff that you talked about was unbelievable. So talk to our listeners about what you do and, importantly, how you got there.
Yeah, thanks, Paul. I still can't quite believe what I do for a day job. I set up Australia's first clinical psychedelic lab in 2020, not because I wanted to set up a lab or help establish a field in the country, but because I wanted to work in the space and there wasn't anything going. And what we're primarily doing at the Clinical Psychedelic Lab at Monash University is running clinical trials using psychedelics with psychotherapy for a range of different mental health conditions. But because we're a front runner in the space, we've found ourselves needing to be a bit more useful in that, at least kind of broadening our scope. And we have been involved in training and other education in the psychedelic space, and we're now moving into a very formal process around psychedelic education and training, and we've been involved in all sorts in policy development. Obviously, Australia is a very rapidly changing context in the psychedelic space. In fact, I'd say globally, Australia has gone through more change in the psychedelic space than any other country in the last few years. So it's a very, exciting, dynamic, complex space to work in. And I really feel very grateful to have work that is both interesting and seems useful.
Yeah, look, absolutely. And we will dig into just how useful it is, because seeing your presentation, I was like, oh my God. And I've been following this space for a number of years. And I'll tell you where my interest started was way back in 1996, when I started to do a master's degree in social anthropology. And the first subject that we did was shamanism. And I got really interested in shamanism to the point where I packed in my master's degree and went off traveling and ended up in South America, and had a really interesting experience with an Inca medicine woman named Dorda. And I went and did a psychedelic journey with San Pedro cactus, with the active ingredient is mescaline. But interestingly, I was into it for exploring consciousness. But there were two other people who were in that session, one who was a drug addict and the other an alcoholic. And they had been through all sorts of treatments. And they said to me that the stuff that she was doing with them was just light years ahead in terms of the impact that it actually had on them. And then I started looking into the ayahuasca church in Brazil that had like crazy remission rates for alcoholics and drug addicts. And I have actually done a whole heap of shamanic journeys in the Amazon jungle with ayahuasca, which is a pretty potent hallucinogen. So that's where my interest, it was a personal interest. Yeah. And I've kind of kept an eye on this space because I was like, why isn't this stuff being done in mainstream? So just give our listeners a little bit of a history of this, because there was some stuff in the 1960s, wasn't there? And then it got kiboshed for quite a while.
That's right. Yeah, in fact, many of us think of this phase as the third wave of Western psychedelic science and therapies. The first wave was in the late 1800s, early 1900s, and very, very dappled history of Westerners having interesting adventures in indigenous contexts and bringing back stories and products and writing theses on these encounters. But a far more productive phase kicked off in the 1950s, and for close on 2 decades, there was an uptick in psychedelic research and practice. Now, a lot of this work happened in that second wave prior to the prohibition of drugs like LSD and psilocybin and MDMA. So they were implemented in clinical practice alongside being tested in a lab. It wasn't like you start in the lab and then when it's proved up, you move to the clinic. It was a very productive phase. I mean, we look back on that phase now with mixed feelings, I think. In many respects, the clinical science of the day doesn't hold up to the contemporary standards that we require when we judge data. So the data is a little harder to interpret in a modern context. But it was also very productive and very experimental. LSD was the main drug being trialed and tested for a range of different psychiatric and addiction issues, principally alcohol use disorder. And there was, a whole set of fascinating experiments from using, moderate dose LSD with active psychotherapy, which is called psycholytic psychotherapy, something that has still not been retested in the modern era, through to some rather unfortunate misadventures, for example, trialing out LSD for schizophrenic children. And, there was a whole host of experimental work done. And some of it was great. Some of it was fantastic. An estimated 40,000 doses of LSD were given in controlled settings, and there were multiple international conferences and big, about 1,000 research papers. And then, what's now the famous kind of war on drugs kicked off, led by Nixon's administration in the US, but ratified through UN conventions and a set of international treaties that really left only a very small handful of countries around the world allowing psychedelic drugs to be used legally, and the vast majority of the world banned them, and banned them in the most prohibitive way, put them alongside drugs like heroin and crack cocaine and labeled them as dangerous with high abuse potential and so on. Now, there were many factors actually that contributed to the demise of that second wave of psychedelic experimentation in Western psychiatry, but it seems that, and history seems to bear this out, that the majority of that was driven by a kind of propaganda campaign, which was predicated on a set of lies. If you are to schedule a drug as a Schedule 1 substance in the US, which is roughly equivalent to a Schedule 9 in Australia, then you have to show that drug has a high potential for abuse. That means it's highly addictive. And you also have to show that it's got no known medical value. And at the time that happened, 1970, there was already about 2 decades of research indicating exactly the opposite. In fact, drugs like LSD and psilocybin, the active ingredient in magic mushrooms, are anomalous in the context of psychotropic agents. If you have a drug that produces very strong psychoactive effects, typically there are a whole set of side effects as well, and you get to toxic doses pretty quickly and so on. With drugs like LSD and psilocybin, you get the most unbelievably potent psychoactive effects with negligible physiological harm. So they're quite anomalous. Even caffeine can be more harmful. So, fast forward to 1999, and a small group of brave researchers kicked off what is now considered the third wave of psychedelic research, sometimes referred to as the psychedelic renaissance. And that was a group at Johns Hopkins who quietly kicked off an initial study. Interestingly, it wasn't a psychiatric study. It was a study with so-called healthy volunteers, and they published that in 2006. And over that subsequent 10-year period or so, the beginnings of the field took shape. And probably in the last just 4 or 5 years, we've seen just a very clear exponential uptick in productivity and commercial interest and general community awareness of psychedelics. A lot of people who know about psychedelics found out about them in the last few years. The majority of people, I would say. And so, yeah, now we really are in an interesting phase right now. I would suggest we probably are rounding out or coming down from the peak of what some people call the hype cycle. There has been a lot of hype around psychedelics and a lot of misinformation about psychedelics. And we're starting to see the beginnings of less impressive results than the earlier trials, maybe some negative reports here and there and some criticism in the field and so on. And I think that's natural to be expected. It's healthy. My hope is that the field, course corrects to, best practice in clinical work and rigorous science, and we can avoid what comes after peak hype in many of these models, which is, a trough of disillusionment. I hope we can avoid that and kind of flatten that curve into, sensible, rigorous, well-integrated clinical practice in the space.
So let's talk now about some of the stuff that you're doing in the lab and in the clinic, because you're doing some of the world first stuff. And I think you probably hinted at it there where you were talking about, all this excitement and then some negative results. Presumably getting a really rigorous intervention is really key, right? An evidence-based intervention that you can then replicate over and over again to get really good data, rather than having lots of different people doing lots of different things, some just using psychedelics without psychotherapy, some using it with psychotherapy. So tell me the sort of stuff that you're doing and give our listeners just a bit of an insight into some of the rigor that goes into the planning of this sort of stuff.
Yeah, thanks, Paul. Before jumping into a little bit of a picture of our lab at Monash and what we're doing and kind of what the next 5 years looks like in our view, it's worth just touching on something you hinted at there, which is what I think of as the most damaging and pervasive misunderstanding or maybe misrepresentation in our field. And that is that a lot of people still think that most of this treatment is about a drug, or even that it's all about a drug. When in reality, in our experience, in our view, and in the trials around the world, when psychedelics work well, they work well on account of augmenting psychotherapy, on account of facilitating a psychotherapeutic process. Now, in all trials so far, that's a formal psychotherapy program. Oftentimes, you're receiving about 4 times as many talk therapy sessions compared to drug sessions, and they'll sometimes be every week for 3 months. Depends on the trial, and I can tell you a bit about our different trials. Even when, whether that's kind of very extensive or more minimal, it is a psychotherapeutic process that gets facilitated with the aid of these drugs when it works well. And if you think about it, clearly when the drug is in your system and the acute effects are at their peak, that experience is driven by the drug. You've got a compound there's got a molecule that's crossed the blood-brain barrier and it's docking receptors in your brain and causing an effect. Now, for the days or sometimes weeks after your dosing session, people will sometimes report what we call the afterglow effect. They might feel spontaneously different and maybe behave differently as well. They might feel more emotionally open or labile. They might feel connected to their priorities or decide to go for a stroll and listen to music instead of just work until dinner time or whatever it might be. And some of that may be also driven by some of the drug effects or the kind of post-drug reverberations in your neural networks as it comes out of your system. But with most of these drugs, the half-life is in the order of 6 or 8 hours, and clearly a week or 2 or 3 later, the drug is out of your system. And if you're going to see somebody's life transformed a year later, that is clearly not on account of a drug still working in your brain. The drug is gone. It facilitated an experience. It gave an opportunity for some sort of transformation. And then if it works, it's because some psychotherapeutic and maybe behavior change process was triggered, and it's a virtuous cycle of learning and growth and development and so on.
And it sounds to me with that description that there's a bit of a combination of the drug inducing massive neuroplasticity, and then the psychotherapy, which may have an effect in and of itself, but then the psychotherapy then kind of steering that neuroplasticity to psychological flexibility or just changing behavior, changing goals, sense of meaning, purpose, that sort of stuff. Is that kind of what's going on?
Yeah, that's one lens to look through at this, and I think that sounds right to me. There's also perhaps other lenses like more psychological or experiential or psychodynamic lenses to look at this through, where people might have a profound experience. The psychedelic experiences are often rated as one of the most profound of a person's life. I mean, this is one of the amazing things about my job, because it's, today's Monday. It's just another Monday for me, but we had an MDMA dosing session today. Today might be, one of the transformational or pivotal moments in that person's life that came to our lab today. And it's...
I mean, there's a long history, like thousands-year-old history of reported ecstatic experiences, right?
And so sometimes it's ecstatic, and other times it's extremely painful. I mean, often we are facilitating some of the most challenging experiences of people's lives, but the value doesn't depend on whether you happen to feel good or struggle. The value is in a completely different kind of orientation to your life or yourself or your history. And for a lot of people, they're getting this kind of contact moment, like an unprecedented contact, usually with at least the sources of their distress in their life and maybe their pathology. Yeah. But sometimes it's a connection or a contact with their priorities or the people that matter, or it is like a realignment. We often talk about kind of compass setting in this work. Now, a compass doesn't get you to your destination, and that's what psychotherapy is for. Yeah, so the psychotherapeutic container does many things. I mean, in the preparation phase before your first dosing day, it's mostly kind of gearing you up for a safe and productive journey. We get the launch pad sorted, we get the rocket facing in the right direction. There's a whole lot of work to be done to ensure that you have a very good chance of going the distance and not fighting. And in reality, every psychedelic journey is quite different, but the critical thing that we need to take care of on that launch pad before we launch is trust. Because without trust, we fight these confronting experiences. In fact, psychedelics are in strange ways showing people the kinds of experiences or perspectives that they've spent a huge amount of time and effort trying to avoid their whole lives, but from a bit of a different angle. And there's a lot of challenge, and there's a lot of potential for distress unless we can teach people the skills and the knowledge around how to kind of trust and let go and be open and go for the ride. And if you can do that, then who knows what will be shown to you, but it's often unbelievably productive. People will feel like they're in a waterfall of psychotherapeutic material. Like this, just barely have they managed to digest an insight or a priority or a perspective or a feeling, and the next one is falling on them, and the next one again. And so the biggest challenge we face, I mean, it's quite clear how we set the launch pad up. That's actually, you can protocolize that, and we can guarantee that, all but guarantee that we set that launch pad up well. The bigger challenge for our field is that you stand under that psychedelic waterfall with thimbles, little thimbles, and that's what you've got to take into the rest of your life. And so one of the tasks of a psychedelic therapist and a whole protocol is to turn those thimbles into bigger buckets and find ways in which those buckets can be refilled without the drug. And what I'm talking about here is the durability of effects. We can get a high rate of incredibly profound, useful psychedelic experience, what people often call transformative experience, but there's a difference between these peak experiences and real transformation, because the challenge of the human condition and the challenge of mental illness on top of that is monumental. It's so great. We really are up against decades of habits and billions of years of evolution, and so this is, I come back to this misunderstanding, and it's a kind of magical thinking, this idea that a person who is deeply distressed and has entrenched pathological behavior in their or thinking can take a drug and that they are sorted forever based on that one drug. That's magical thinking.
Yeah. So, mate, you've made several references to the launch pad, and I remember when we were talking at the YPO gig, you said psychedelics are a rocket ship for psychotherapy. If you're going to be in a rocket ship, you want to bloody well steer this thing, and that's the role of the psychotherapist, right? So, as you really pointed out there, it's not the psychedelics by themselves; it's that combination with the therapy. So tell us, what are some of the things that you are doing, some of the trials that you have done, now that we've got all of that context set up for people? Because I think it's really important,
Sure.
Right?
Yeah. So we finished up a few studies and psychedelic trials in the lab already, and I'll tell you a bit about those. And then we have a couple ongoing and a couple that are coming down the line. The first study we finished actually was a study where we gave psilocybin with support to our therapists as part of their training. And the basic question there was, is there a role for having your own psychedelic experience in your competency as a psychedelic therapist? This has become a theme in our lab, and one of my students is leading this work currently, where we're looking at the broader topic of psychedelic therapeutic competencies and building a framework based on prior psychotherapy frameworks to understand what is unique and what is overemphasized in the psychedelic space. What does it take to train a good clinician in the space and to assess their competency and so on? And then in addition to that, is there a role for having your own psychedelic experience in that competency? Does it do something important? And, the paper is forthcoming. We'll publish that soon. But the punchline is a resounding yes, it is. It seems to be incredibly useful. And it also accords with common sense in the space that having your own psychedelic experience does potentially improve your competency to be a good psychedelic therapist. Although I'd say a few things. One is that is in the context of people who are already trained as clinicians and then who have already had a psychedelic therapist specialist training, and then they're getting this dosing exposure on top of that. And most people indicated, and we assessed both the therapist and then we assessed all the patients who they treated afterwards on this.
Oh, wow.
People would generally say, yeah, but it's not necessarily the most important thing. I think many people would agree. You would rather have a well-trained, qualified psychotherapist than somebody who's not at all trained or qualified but has had lots of psychedelic trips. So we ran that study. We can also see that a huge majority of patients prefer and sometimes demand that their therapists have had psychedelic experience, and they'll generally make appeals to the kind of common sense metaphors like, how could you have a tour guide who's never been to that country or something like that. And
Correct.
You can make the case even more strongly for, another planet, a tour guide on another planet.
Yes.
So that's an exciting program of work, and I'll talk to you soon about our planned Center of Excellence that we are planning to launch next year. One theme within the trials component of that center is to further develop our therapist training competencies work, including running an expanded trial where we give therapists different psychedelic drugs, and we use our new developed tools to assess their changing competencies over time. So that was exciting. That was a world first approval to give psilocybin to therapists as part of their training. And then that group of therapists went on to work on another world first trial that we concluded earlier this year, which was psilocybin-assisted therapy for severe generalized anxiety disorder. And that was the first psilocybin trial to look at a primary anxiety condition. We'd seen in previous trials that psilocybin was useful in reducing anxiety symptoms for people with physical illness, people that maybe were given a terminal diagnosis and were anxious because they were told they were going to die. But no one had ever looked at psilocybin-assisted therapy to treat, chronic, entrenched primary anxiety, the kind of anxiety that will often have an onset in late adolescence and stick around for the rest of your life.
For decades.
And be related to anything and everything. That was a wonderful project, very challenging in many respects. We treated 73 participants on that study. Again, the paper is forthcoming. but the headline there was the safest psilocybin study in the modern era so far. The safety on that study was better than any so far. And that's measured in terms of what are called adverse events and suicidality. And the clinical effect size, or the size of the benefit between the group that received psilocybin and the group that received placebo, a different active placebo drug, was a very large effect size.
What was the size? What was the number?
So if any of your listeners are nerdy and like their Cohen's D, it was a Cohen's D of just under 1.
Wow.
Yeah. So Cohen's D of about 0.3 to 0.5 is considered good. Most of the treatments that are approved and registered and you can get prescribed have had trials that show Cohen's D of 0.3 to 0.5. If you get 0.8, it's considered big, large, and we were at about 1.
So let me give the listeners a little bit of context here, Paul, that antidepressants typically have a Cohen's D of about, depending on the particular drug, 0.3 to 0.5. So, 0.2 marginally better than placebo. Yeah. Anything better than that is reasonably good. But when you're talking about some of the side effects, when we take antidepressants, recent study of 1,800 users, right, real world people, showed that more than 60% of them were having really, really challenging side effects, right? So your drug, both in terms of, your intervention, both in terms of the effect size. Now, I know that was generalized anxiety disorder. I'm comparing against depression, but I think you probably have similar effect sizes for medications, I'm guessing, for anxiety disorder. And because the medications, a lot of them are antidepressants for anxiety disorder, right? So you'll see, so this completely outperforming, like by almost orders of magnitude.
That's right.
Both in terms of the safety and in terms of the impact.
That's right. And so the critical question, there's two big questions. One is, do those benefits endure? What are those people looking like in 6, 12 months, or further down the track? We've now done our 6-month follow-ups, and we can say that the benefit endured very well to 6 months.
Wow.
We will do 1.5 year, 2.5 years, 3.5. We will continue to assess them. So that data is still coming in. And we have some ideas about, how to improve durability through, low-cost forms of integration and support and so on. There are all kinds of things that can be deployed. The next critical question is, can you replicate that? Can that be done, at a new clinic or a new site and so on? And that's a complicated one, because this is psychedelics with therapy, and the type of therapy that is involved and the type of therapists that have been involved are not just run-of-the-mill. And, not to disparage anyone. Most therapists have good training and attempt to do a great job. But these folk have been kind of handpicked as, incredibly excellent clinicians, psychiatrists, psychotherapists, psychologists. They've all been, trained in a very intense way. And they have poured in a lot of care into this work because it's experimental, because it's often a passion project, because they are so kind of motivated to work in this way. And so that's part of why we have this big focus on capacity development in our forthcoming center, because we're wanting to understand what are the critical elements of being a good psychedelic therapist, what are the critical elements of good psychedelic therapy, how do we operationalize that, how do we train that, how do we assess for that. It's not going to be a cookie cutter approach, and this treatment model, if it's going to work well, if psychedelics fulfill their promise, then I don't believe they will fulfill their promise by being, a drug therapy or a cookie cutter model or something that we can just kind of run off the pipeline and scale up in some extreme way. I think it'll depend on nuance and human factors and, the wisdom and depth of the ecosystem around it, if we're going to see unprecedented outcomes continue into the future. I don't think this is a kind of key challenge for the field now, because of course, when something shows a signal, the next typical step is scale. That's great. We got this. Let's move it out. And of course, there's a possibility that the baby's thrown out with the bathwater as you scale. And my big question, in the next 5 years is how do we responsibly scale without sacrificing, the impressive results, the transformational experiences, the growing community of practitioners in the space who are invested in high quality work. It's not only about using psychedelics to facilitate change in a patient's life. It's about seeing whether we can use psychedelics to facilitate change in the mental health care system.
Well, I was going to say, I would presume that you have one eye on the naysayers in the mental health system who are looking for any excuse for this to fail. And so I would imagine you're having to step forward a lot more carefully than you would do if this was just a brand new field with no existing dinosaurs, shall we call it, in the field, or people with vested interest against it. Right?
Yeah, that's right. I mean, there's the old stigma, that these are drugs and they make you crazy, and then there's the new stigma, which is about the evangelism of the field. And I understand that concern, and in a funny way, this is the strange place I work, at this interface between stigma and hype. It's right there, and both of them feed off each other. And really, the future depends on us striking a very clear course through the middle of that, with our eyes on the future of our patients, the very real people who depend on us. Because that is, the whole project of science is all about remaining in conversation with reality. There's all kinds of endeavors that human beings engage in. The scientific endeavor is one in which we try to remain in conversation with reality, pare away our biases, etc., test it, try, retest it. And in this case, the critical reality to keep our eyes on, the critical thing to remain in a relationship with, is the reality of real people's lives as we treat them, after we treat them. And sometimes that gets lost in the numbers in a paper or some public announcement or some commercial deal or whatever. I think there's so much promise in psychedelic therapies, but I think it's not a straightforward thing to do a good job of it. And if we're going to figure this out, we're going to need to stay very close to real patients and their real stories and their real futures. And I think, there are naysayers out there for sure. That's fine. I think there's a whole lot of diversity emerging in the space, and I think a healthy ecosystem is a diverse one. I think opposition and competition keeps you sharp. That's all. I welcome it all. What I am concerned about are the inherent biases that seem to be in our space that can lead us away from remaining in this kind of conversation with reality and getting good outcomes in the end. And those biases are towards scale and toward profit. And it's an alliance between the regulators who have built systems that regulate drugs and not therapy, and commercial ventures that can make more money out of products than services, and so on.
Yeah, no, I get that. Just a little aside a minute, and then we'll come back to the stuff that you're doing and about to do. Is there a clear reason in your mind why the FDA quite recently knocked back ketamine was it a treatment for depression that they was just going through approval and the FDA knocked it back?
Do you mean MDMA for PTSD?
Oh, maybe it was MDMA rather than ketamine. Maybe it was MDMA for PTSD.
Ketamine in the form of Spravato, S-ketamine, was approved by the FDA a few years back for depression. Although that's, people argue about this, it's not really a psychedelic treatment in the way that it's delivered. And it's certainly not with psychotherapy. But no, MDMA-assisted therapy got knocked back in a recent application. And basically, that whole program of work was probably delayed by a year or two. It's not to say that train is derailed. It's just probably delayed. And it's a particular program of work headed up by MAPS, the Multidisciplinary Association for Psychedelic Studies. So, of course, there are many other companies and trials around the world and different universities involved in MDMA and other psychedelic work. That it's complex as to why that got declined. And it's controversial. There are many different perspectives on it. I don't really want to weigh too heavily in on it because I really don't have view in under the hood, both on the FDA and the MAP side. But what I
Sure.
can say is, MAPS are an unusual organization. They're a grassroots pharmaceutical development company, which is kind of almost a contradiction in terms. They started in 1986 got founded by Rick Doblin, and he put in this unbelievable, long and valiant effort to raise nearly $200 million in philanthropy and to basically build an organization, initially a charity, and then it branched into having both a charity and a for-profit public benefit side. And while I know a lot of the group at MAPS well, and I think there was a lot of good work and a lot of good intentions, and they focused on what many of us think of as the priorities, doing good clinical work and so on. They probably didn't dot their I's and cross their T's to the degree that a big, well-heeled pharmaceutical company does. And so there were these kind of, there was an accumulation of little anomalies. I've never had any reason to suspect the integrity of their work, but technically there were some question marks, and they were asked to get more data.
Okay, so it's a watch this space on that one. Okay, so back to what you guys are doing in the lab. Are you just using at the minute psilocybin, and then what other studies are you doing now, and what ones are there in the future?
Yeah, great. So currently we're in the final phases of recruiting for 2 trials, and the first is MDMA-assisted therapy for post-traumatic stress disorder, specifically in the treatment of veterans, military veterans and first responders.
Yeah.
And that study is in its final stages of recruitment. We've treated a number of people. There's a total of 24 people that we're recruiting for that study. So it's a smaller study, although it is by far the largest MDMA for PTSD study in the country. And it's got a few innovations to it. It's focused on PTSD acquired during adulthood in those particular roles of being veteran or first responder, military personnel first responder. And we've also built the treatment to be potentially more cost effective and more acceptable. One of the key complaints that many trials and groups have received in the space is that while the treatment is incredibly intense and profound, the end of the whole treatment package comes very suddenly. And because it's not a service, it's a one-size-fits-all, clinical trial design, people will often feel like they've plumbed the depths of their psyches and formed these unbelievable bonds with their therapists, and the work is really unfolding. Maybe they're even destabilized. We have this kind of post-operative pain phenomenon as well, analogously. And then, maybe 2 weeks after the last dosing day, they say goodbye to their therapist.
Bye. Right. Yeah.
It's a big cliff edge. And so we've tried to build that trial in a manner that doesn't have the cliff edge, that holds them for quite a few weeks afterwards, or a couple of, more than a month afterwards, and also is a kind of program that we think could be actually feasible to just lift out of the lab and put in the clinic for that kind of patient group. Whereas PTSD, that's far more complex, that's typically related to early adverse experiences and so on. It's generally less feasible to say, well, we've got a 2-dose, 3-month package, and that's it. Usually longer term care is required in those situations.
That makes perfect sense.
Yeah, so that trial is ongoing, and then we have another trial. We're a site on a multi-site trial that's sponsored by Beckley Psytech in the UK, and that trial uses 5-MeO-DMT with psychotherapy in the treatment of depression. And so for listeners who aren't aware of 5-MeO-DMT, it's derived from the poison of a Sonoran desert toad.
The toad. Yeah.
And it probably doesn't have a very long indigenous history of use. Probably was discovered quite recently. Maybe even the initial uses were in the 70s, when somebody thought to squeeze the venom out of the gland and smoke it in a hot pipe.
Yes.
The creative innovation of our species. We use this.
And is that different, Paul, to regular DMT and its chemical composition?
Yes, it is. It's only very slightly different in its molecular form or structure, but its psychoactive effects are actually very different. In some ways, at the opposite end of the psychedelic spectrum. So the DMT that you're referring to, which is called NN-DMT, and DMT stands for dimethyltryptamine, NN-DMT is a very rapid onset and very intense and very hallucinogenic drug. It takes people into what they'll often report as other realms, where they'll often encounter other beings or agents, and they'll often come back with a sense that those agents or that space has its own independent reality of my experience, more like I kind of traveled there through a porthole of DMT and discovered another place, rather than that was my mind.
Given it's the active ingredient in ayahuasca, I can attest to that experience. Yeah, I was just wondering if that was a different thing because it's
so 5-MeO DMT from the toad is hardly hallucinogenic. It's more like white light and ego death. It's very intense. It's also rapid onset, and it's less clear at this point how it will work and how to work with it with psychotherapy. Compared to psilocybin and MDMA, we really do know a lot about how to work well with psilocybin and MDMA. We're still, working many things out, but the basics of the fundamentals are very clear. We understand when it works. We know why it worked in general. With 5-MeO DMT, it's so fast and so radically different that it's quite hard to build bridges from here to there. And it's just earlier in its stage of development in terms of understanding best practice and also whether it's going to work. So those two trials are ongoing in the lab, and anybody who is interested can go to monash.edu/psychedelics, and there you'll find a page for participants, and there's a little email address. You just email that to find out more. And so on. We'll only be recruiting on those two projects for the next month or two until we reach our quotas. So, yes.
And sorry, just remind me again, the 5-MeO DMT is for
depression.
What? Depression, okay.
And particularly it's for depression that hasn't responded to prior therapies, what's sometimes referred to as treatment resistant.
Right, treatment resistant. Yeah, okay, cool. And I was going to ask, just on that, what and you may have just answered the question by the study that you're doing, but what in your mind are the psychedelics with the greatest potential for treating depression?
Yeah, my sense is that psilocybin, which has got the most evidence to date in the treatment of depression, is, clearly the front runner. It makes a lot of sense for why it's useful for depression. We know how to work with it with psychotherapy. Again, I think there are more questions around what does best practice look like and how do we get durable outcomes and all of that. But certainly the best evidence we have so far is for psilocybin in depression.
Okay.
There is, and then MDMA is the best evidence we have for PTSD is for MDMA-assisted therapy. And then there are a whole lot of ideas out there that haven't yet been tested. I'm quite keen to do some of this work in the near future in combining MDMA or an MDMA-like drug with psilocybin or another classical psychedelic type drug over the course of treatment. Not necessarily in the same dosing day, although that's of interest too, but more over the course of the treatment span. MDMA is not really a classic psychedelic. It's what's sometimes called an empathogen. It massively increases your tolerance for distress and allows you to feel incredibly comfortable, comfortable to the degree that you recognize that you and I and everybody are pretty much a bit anxious all the time, at the very least. So this profound comfort can set in, and that allows you to explore your mind or your history or your life or your priorities in a far less constrained way and in a way that feels more sober or more broad or more flexible. I mean, psilocybin and MDMA do quite different things, but both of them, I think, open up Huxley's reducing valve, if you like, by analogy. Aldous Huxley referred to this reducing valve, which constrained our perception and our thinking and our behavior towards our survival prerogatives. And, my sense is that reducing valve is tightened through anxiety, and MDMA's path to releasing that or loosening that valve is through allowing people to feel incredibly comfortable. MDMA could be very useful in kind of commencing a treatment journey where people can not only feel comfortable, but feel a lot of compassion for others and for themselves. and just have the sense of safety that I'm able to start exploring the things that are under the surface or that I've avoided. And then psilocybin, could be a fantastic next session that allows people to have often far more profound, dramatic shifts in their perspective, or visionary kind of lessons that assist them in their lives in difficult to predict ways. And then MDMA, again, may be a good way to kind of round things out. So there's all these ideas about how we combine these drugs in the future. And I think the future of psychedelic therapy is a far more diverse thing than the models of care that we see today in the trials.
Yeah, wow. So that lends me to think about the next question I have that just popped into my head. I read a research paper recently. I only sped read it. I've got to go back to it, where it was shown that in depression there were different functional brain networks that were amplified. So, are you doing, or do you have plans to do functional MRI scans of people pre and post treatment to see if there are any specific areas of the brain that are changing in terms of activity?
We may do that in the future. We haven't done it yet in our lab, although many of our colleagues around the world have done these kinds of brain scanning studies for sure. And it's interesting to note, and we've seen, some consistent signals, for example, with psilocybin dosing. You refer to hyperactive regions in depression, and we've seen some of those typical hyperactive regions in depression downregulated or go more quiet under psilocybin. The two most common or consistent patterns with the neuroimaging studies with psilocybin are that psilocybin and LSD, there's been some LSD studies as well with imaging, these drugs cause what's called your default mode network to get quiet. And this default mode network is kind of your brain's idle mode. It's as it says in the name, it's the default activity of your brain. And what it typically instantiates are thoughts about yourself and how things relate to yourself, thoughts about the future, thoughts about the past. It's called mental time travel, abstracted thinking, and so on. And if you think about that, if you actually think a lot about the past and the future and yourself, it's actually a recipe to get depressed, even if you weren't to start with. And so that goes down and it quietens down, and through a process of disinhibition, other areas light up. Another common pattern in psilocybin imaging work is that parts of the brain that are typically not, quote unquote, in conversation get in conversation. So what the majority of the nerve cells or the neurons in your brain are what are called inhibitory neurons. They dampen down other neurons. And that's a good thing because our brains need to be highly specific or specialized in the tasks that they're achieving. A lot of people will say, what a shame you only use 10% of your brain. Wouldn't it be great if you could use 100%? No, it would be chaos if you used...
It'd be crazy,
it would just be... You'd be seeing everything, hearing everything, and doing everything at the same time. So the thing is, when you activate a certain network in your brain, part of what it's doing is inhibiting other networks so it can be specific. It can do that job. It can think that thought. And so we have quite distant nodes in the brain or hub areas in the brain that are what are called anti-correlated. When one lights up, the other one gets dampened, and vice versa. They kind of are in competition with one another. And under psychedelics, they light up together. And so this does a couple of things. One is it makes you less functional, like it's hard to drive a car or have a conversation.
Yes.
And the other thing it does is it allows you to join distant dots or to have a feeling about a thought when previously it was just an abstracted thought, or to just connect things in quite different ways. And so that might be the neurobiological correlate of the very new and deeply felt perspective that psychedelics tend to confer. But I guess what I would say is, while I'm interested in the neurobiology of this, I would say that we are getting far more granular in understanding how psychedelics work and how to do a better job of it through what's called phenomenological inquiry, asking people about the nature of their experience.
Yeah.
Because these experiences are so complex and profound, and my guess is that we are a very long way from the neural correlates of what matters under psychedelics.
Yeah, I can see why that is the priority, and the looking at the networks is the icing on the cake once you've sorted everything out and how it actually works. A couple of comments actually on the default mode network. The Dalai Lama has for years run this thing called the Mind and Life Conference, where there's a bunch of neuroscientists and Tibetan monks who get together. And when Richard Davidson, who was one of the first researchers to talk about the neuroscience of meditation, when they explained to the Dalai Lama the default mode network, he said to them, you mean monkey mind, yabba, 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 right? And it strikes me that increased activity in the default mode network, you mentioned about thinking about the past, thinking about the future. In Japanese psychology, they say it's about the flashlight of your attention, and that people get in trouble when they shine the flashlight of their attention in their own heads for too long.
Interesting.
Right? Which is kind of that nice analogy to that overactive default mode network. So man, I am aware of time. I'd love this to go on for hours. I really would. But what are some of the next steps for your group?
Yeah, thanks, Paul. So I am most focused on and most energized by our planned Center of Excellence that we're intending to launch early next year. The reason for that is that over the last 4 years or 5 years, we have not only seen the promise of psychedelic therapies, we've seen all the kind of complex factors that need to be coordinated for that promise to be fulfilled. And in many respects, my view is that if we don't achieve a set of key outcomes over the next few years, that promise is in peril. And so the center is attempting to move beyond one trial, one question, one project, or one course at a university, etc., into a more coordinated venture with interlinked parts. And there are 3 interlinked parts, but then there's multiple parts beneath those. The 3 parts are innovative trials, and we'll be doing a number of world-first studies that I'm very excited about. And it's the kind of studies that are either not commercially obvious to an industry funder and maybe too early or complex for government agency to fund, but nonetheless are the kinds of trials that have a high probability of success and high impact if they do. And so that is the perfect remit for philanthropy. And so this center will commence with a philanthropic call, and anyone who's interested in finding out more can reach out to me through our website. I'll tell you a little bit about some of these studies that I'm so excited to kick off. In addition to that pillar, if you like, we will have another pillar which is around education and training. We've run a number of trainings around the country. We've trained quite a few groups that are doing this work around Australia with a lot of assistance from international leaders in the space. And we'll continue to run various training programs. And we've just last week got approval to commence our psychedelic education program that's Monash accredited, which is very exciting. So we commence it with 4 courses, 2 undergrad and 2 postgrad courses in 2025. And they will build from there into proper is the wrong word, into substantial psychedelic therapist and prescriber trainings that have full university endorsement and go through all the are aligned to the research and best practice in the space. And then there's a third aspect to this center, which is around immediate impact and real world impact at scale. That includes everything from standards and frameworks through to health economics and working up the right kinds of data and the right kinds of relationships that can allow for far greater access as the different programs of work show themselves to be safe and effective. So, we might discover that, for example, psilocybin-assisted therapy is indeed safe and effective for depression, but if it costs $30,000 for a standard course of psilocybin-assisted therapy and no one in the insurance sector or government will fund it, then it's going to remain niche and inaccessible. And that's a problem. So we are really focused on access and affordability. And if we can show that the promise of psychedelics can be fulfilled, if we can get the durable outcomes, the high rates of remission in the long term, then it will save the payer money, whoever the payer is.
Right.
And in the case of reimbursers, they will want to reimburse it. So that is a critical step. And so just a final piece on that center, which is to say, the idea with having these multiple interlinked parts is that what we can do in a center like that is greater than the sum of its parts. It all feeds off each other, and it all informs each other in terms of efficiencies, in terms of knowledge and translation, and so on. It'll be multi-institutional, have a whole set of international stakeholders and national stakeholders, and the express mission is to add value using psychedelic therapies in the mental health space without the biases and the limitations of industry or government or university or whatever it is. We're keeping that patient clearly in view. That is the primary thing we're focused on. And so I'll give you an example of one of our innovative trials that'll be an initial flagship trial that we'll kick off early on, just as an example of many. It's a study that is using MDMA-assisted therapy to treat co-parents with high levels of conflict.
Oh, wow.
So this is not a psychiatric study. We're not treating a mental health disorder.
Yeah.
In fact, because you cannot diagnose a relationship, you cannot get an industry sponsor to fund a trial like this because the regulator doesn't know how to regulate a drug for a relationship. But we can do it through philanthropy. We can actually get it to market, if you like. And the idea here is that this is one for the children.
I mean, I was about to see you just give me goosebumps on that, because if you can help with relationships, you know what we know is one of, as you well know, right? But one of the biggest drivers of poor mental health is coming from a broken home.
Totally. I mean, the people argue about this, but I would say, and it looks like the evidence really suggests this, that the single biggest predictor of psychopathology and addiction is early adverse experiences. And that's often in the home, but being exposed to big T trauma and little t trauma. Little t traumas behind every fourth Australian suburban door, what are considered to be problematic high levels of conflict. It is a problem that's hidden in plain sight, and really, like the idea here is we are dealing in the mental health space in a reactive way. We're dealing with the effects of early traumatic causes, and what we need to do is deal with the causes. So
yeah, absolutely.
So I'm
and add to that list, mate. It is one of the biggest predictors of PTSD in the military. Being ex-military, is that early life stress and drugs or alcohol in one of the parents, right? Answer yes to those two questions, and you are very likely to get a PTSD out of combat. This has been unbelievable. Look, I have a brilliant job that I absolutely love. You're one of the few people who has a job that I'm a bit jealous of, I've got to tell you. You are a modern day explorer, because, this is, for me, it's something that really has to be explored, and it's very, very important work. So, mate, I tip my hat to you, and also the rigorous way that you're actually going about this, and the fact that everything is about patient-centered. I think that's bloody awesome, and it's a credit to you and your team. So, mate, keep doing your awesome stuff. Now, just tell us, where can people go to find out more about you and your work, and importantly, if they want to also contribute philanthropically. I know from both an individual listener perspective, but there's also people who listen to this podcast who are involved in health insurance and life insurance. And I think that they are people, are organizations that should be looking at funding this. So where can people go to find out more, and also to support what is a very necessary cause? Thanks,
Paul. Really appreciate the support and your kind words. Yeah, just to say, I feel incredibly grateful to have the work I do have, and a big shout out to my team. It's not me, it is 40 of us in our group, and these are tremendous human beings who are amazing on the tools and have got such bright minds and such good hearts, and this work, it takes a village. So it's important to just acknowledge that there's a big team of us as well. To find out more, monash.edu/psychedelics. And by all means, if anybody is interested in finding out more about our planned Center of Excellence and maybe has an interest in understanding what we're trying to achieve and so on, please write to me through that website and we can arrange a call and maybe a visit. We've got a wonderful lab in Victoria.
Awesome, mate. Thank you.
Great. Thank you, Paul.
Just bloody awesome.
Appreciate it.